The journey of caring for a loved one who is living with dementia can be quite challenging. The aim of this podcast is to make caregiving less daunting and more fulfilling. On this platform, we share knowledge, understanding, and experiences. We enlighten, give hope, and encourage, and in the process, create positive awareness about different aspects of dementia. Welcome to my podcast, Dementia Caregivers Corner. My name is Julia Ratladi. Dementia Care, how deep is your love?
In today's episode, we are honored to have with us again the remarkable Isabel Baker from Australia. Isabel, as mentioned in our previous episode, is a retired clinical nurse consultant with over 35 years of experience in dementia care. She is also the author of the A to Z of dementia care and offers Zoom sessions to help carers better understand the lives of those living with dementia. In her last visit, we explored grief and the key concepts from her book. Today, we will look into the core care principles and the emotional aspects, as well as the spiritual dimension of dementia care, among other topics. Please, so let us welcome in today's episode, Isabel Baker. Welcome to Dementia Caregivers Corner podcast, Isabel.
Thank you, Julia. It's a delight to be here again.
Isabel, for me, I've gotten into the dementia care space after having interactions with people living with dementia. And I saw how misunderstood they were or how they were not cared for properly. And so I thought I could make a difference in their lives. And so I pursued, I don't know what I call it, a career. I pursued, a career in dementia care, just to create awareness, firstly, about dementia, and then ways on how to assist people living with dementia well. I want to know your inspiration. What inspired you to go onto the dementia care field?
It was accidental. Initially, I needed my husband had left. I needed a small part-time job that would suit school hours. And I saw this job advertised as a personal care assistant. I was already an RN, but this was advertised just as a personal care assistant. And I thought I can do that. It was 9 till 12 or 12:30, 5 days a week. I could get the kids off to school. I could go and do the job, get a bit of extra income because at that stage I was on the single parents pension. And so I applied for it. When I went for the interview, the lady who was leading the interview said, "I don't know why you're still on this list. We asked the secretary to remove all the RNs from this list." And I said, "Look, I'm happy to work as a personal care assistant. You don't have to pay me as an RN. I just need a small part-time job." And I got the job. And it probably helped that the lady who was interviewing me had been the junior nurse on my last ward, where I was the senior nurse when I was doing my nursing training. She was somebody who already knew me. And that really began my interest in dementia. They sent us to Sydney for some really good training with somebody who already was engaged with people with dementia from an emotional level. So he taught us that the emotional connection was really important, and that the communication and how we interacted with the people themselves. Because up until then, I'd had very little experience. I'd had some experience, but very little training in working with people with dementia. In fact, about 2 or 3 years earlier, I'd been reading a magazine. I was on night duty, and it talked about the Aga Khan's wife, Rita Hayworth, developing Alzheimer's disease. And I sarcastically thought, look at that. An important person gets senile dementia and they give it a new name. That's how much I knew. because Alzheimer had named Alzheimer's disease back in 1900 and something.
Okay.
Yeah.
Okay.
Yeah. So, and then from that little job, really interacting with those people on a close level, there were only 12 people in the group, and we really got to know them. We'd take them from their rooms at 9 o'clock in the morning, do activities with them and engage with them for 2 or 3 hours, and then go take them to lunch. And you really got to know their personalities, who they really were. You just knew that you developed relationships with them. You know, we did things like when we'd take them to lunch, we'd say, "Did you have a lovely time today?" And they'd inevitably say yes. And we'd say, "Well, we're going to do this again tomorrow. When I come down in the morning, would you like to come with me again?" And they'd say, "Oh, yes." Now, by tomorrow morning when we went to pick them up, they'd well and truly forgotten what we'd done yesterday. But rather than walking in and saying, "Oh, you're going to come with me and we're going to go and do things," you know, you're expecting me to leave my nice, comfortable room and you're taking me somewhere I don't know where I'm going because I can't remember we were there yesterday. We'd come in and say, "Oh, after lunch yesterday, you said you'd like to come with me this morning and we're going to do an activity together." So you're reminding them that you've already got an existing appointment. And of course they'd come along with us. We'd be smiling, we'd be happy. They had this sense that they knew us, but they couldn't tell you our names. And that didn't matter. We developed this relationship that meant that they trusted us and they'd come along with us. And we had a marvellous time. And that just began, really, my interest in dementia.
Oh, okay. That's quite interesting. I think that there are some things that you have mentioned, but I will talk about them later on as we move through our chat. And so, in your book, let me read something here from your book. You said people with suspected dementia should seek medical attention to establish a diagnosis, eliminate the reversible causes, and receive treatment before they are given a diagnosis of probable dementia. I want to know, what do you mean by that? Do we have reversible causes of dementia?
Well, the person actually doesn't have dementia. That's what we're really saying. They have other illnesses that are causing symptoms to look like dementia.
Okay.
So the person with pernicious anemia may present with memory loss and confusion because of the lack of vitamin B12.
Mm-hmm.
It may eventually go on to develop dementia, but in the early stages, they need that vitamin B12. The person with hydrocephalus, the build-up of fluid around their brain, it's pressing in on their brain. They're showing symptoms of confusion. They're having falls, and they're having problems with their maintaining continence with their urine. Now, put a shunt in to relieve the pressure of the cerebral spinal fluid, and that person will now stop having falls, stop having problems with their urine, and reduce their confusion. Okay. So they're reversible causes of confusion and disorientation.
Mm-hmm.
Same with people with a low sodium level in their bloodstream, or a high calcium or a high potassium. They'll present with the confusion, but rectify the blood levels and the confusion's gone. Somebody who's has a thyroid problem, maybe low thyroid levels, or they've had a thyroid operation and they're just beginning to forget to take their thyroid tablets. Now, gradually they'll look like they've got dementia, but make sure they're getting their regular thyroxine, or they're put on thyroxine if they haven't been, and the confusion will go. So they're the sort of things I'm talking about. There's, they may have a delirium.
Mm-hmm.
may have an infection somewhere in their body that's causing a problem, and suddenly they're confused, disorientated. That sudden presence of the confusion and disorientation, look at what else is happening in their body, whatever, infection, fall, head injury from a fall, all of those things that have happened suddenly need to be treated. And don't do the assessment in hospital. We had a lady in the hostel, lovely Welsh lady, background. And one Monday morning, she was a little more confused. She wasn't somebody who was routinely confused.
Mm-hmm.
And I started testing all the things, had she had a fall? Did she have an infection? Was she constipated? Was she sleeping well? Couldn't find any reason why she was getting confused.
Mm-hmm.
The next morning, she began speaking Welsh to my staff. Well, they knew very well that she didn't usually speak Welsh. So I asked the doctor to do an X-ray just to make sure there hadn't been a fall or something like that. The X-ray came back with a spiral fracture of a hip.
Mm-hmm.
And her daughter told us Sunday night when I brought her back from an outing, I heard a cracking noise as she turned to get out of the door of the car, and I just thought it was the creaking of the car door. It was actually her fracturing a hip. She went to hospital. She had it fixed. And then the hospital rings me as the manager of the hostel and says, oh, she can't possibly come back to the hostel. And I'm thinking, is she walking? What's the problem? I said, is she walking? They said, yes, she's walking.
Mm-hmm.
I said, well, why can't she come back to the hostel? Oh, she's too confused, too disorientated. Well, you and I both know that hospitals can be confusing, disorientating places, even for the best of us.
Exactly.
You can wake up in a hospital bed and think, where am I? Why am I here? How long have I been here? And be quite confused.
Yes.
Well, I said to the hospital, let her come back to the hostel. And if in a couple of days she's still confused and disorientated, I'll send her back to the hospital. Well, she stayed in the hostel 5 more years before she had to go to the nursing home.
Oh.
Because she settled straight back into her normal environment.
Yes.
No more confusing, no more disorientation.
Yes.
So important.
Those are the reversible symptoms that you are referring to, that we have to get rid of those before we can say this is caused by dementia. Or maybe their behavior is caused by dementia. We should get rid of those. Oh, okay. Oh, all right. That's what I wanted to understand. And then, after somebody has been diagnosed with dementia, firstly, what kind of support is needed for both the person living with dementia and their caregivers? And how important is that support, sis?
It really depends on the person themselves and the type of dementia they've got.
Mm-hmm.
In the early stages, if they're diagnosed early enough, they can stay at home, live with their partner or care provider, and it's really about supporting the care provider, giving them respite, giving them time out. I have an 85-year-old lady that friend that two of us visit every week to give us some social interaction. At first, when she had dementia, she would come out with us to the coffee shop and have an outing with us. But then she's got to the stage where for her, she feels the outing is too onerous. She has to get changed. She has to do all of those things. So she doesn't want to go out.
Mm-hmm.
But so we started going to her. Okay. And we keep up that social contact with her every Wednesday. We pick up coffee from Macca's and we take it to her place and we have afternoon tea with her and we spend about 2 or 3 hours. Gives her son a break. He doesn't have to be there. Yeah, one of the services I ran was Riverina Dementia Support, which was totally about looking after the carer, giving the carer time out, but also providing the person with dementia with normalised activities that they enjoyed. So came up with this idea that we could use one worker and 4 people with dementia go to each one's house every week. So one week, 3 people would come to your house and you'd have morning tea with them. And the carer had the opportunity, they could go to the bedroom and have a sleep, or they could go shopping, or they could do whatever they wanted to do while they knew the person with dementia was cared for and safe, and they were at their house. But the next 3 weeks, the person with dementia would be somewhere else having morning tea with one of the other people's places. So it gave 4 people, care providers, respite each week. And it was a normal activity. It was having a morning tea with a group of friends.
Do these people knew each other before, or they just met?
They just met and they gelled together. We had 3 or 4 different groups that we ran like that. And if they didn't get on, we could remove somebody and bring somebody else into the group. But we never had to do that. They all just got on well together. For the men, we did things like taking a group of men fishing or going to their garage and having a morning tea in their garage. So, just that sort of men's business.
I know.
So that's caring for the carer. For the person with dementia, depending on the sort of dementia they've got, whether they need extra help. I spent 2 hours earlier today on a Zoom call with a gentleman in Melbourne and his care worker, who happens to be my niece by marriage. And we discussed the problems that he was having with his wife. Initially, she was very reluctant to have the care worker come. And we realised that she was jealous of the care worker when the care worker and the husband were in the house together. So we arranged so that the care worker now rings and says, I'm at the door. He goes into the garage and goes for his walk, which is what he wants to do during his respite time. She knocks on the door and the lady lets her in.
Okay.
And there's no more jealousy or anxiety. And they've just developed this beautiful friendship together, even though they don't have the same language. One's Chinese and one's Vietnamese.
Oh, okay. You know what? I want you to say that again, because I had a friend who was caring for someone living with dementia. The lady was the one who living with dementia, and the husband was there. And so the lady would be like, you want to take my husband, when the carer is there. So can you explain how to deal with that? Because it's something that happens.
Yes. So, I mean, we dealt with it by not having them together in the house at the same time.
Okay.
So when the care worker arrived, the husband, the thing that he wanted to do when there was respite was that he wanted to go for a walk. That was his desire, was to get out and have about an hour or so's walk. So he would go for that walk, but we had to remove him from the husband and from the house before the care worker arrived.
Okay.
It's about not having them together at the same time.
Yes.
So that was how we dealt with that issue with that. But now, after I first spoke to this couple back in November, so what are we, 7 months down the track, she's now got such a good relationship with the lady that when the husband comes back, initially she was disappearing and the husband would just say, I'm in the garage, and she would disappear out the door. But now when the husband says, I'm in the garage, they go out the front door together. And then the care worker says, oh, look, there's your husband. And now she's quite happy for the 3 of them to be together. So it's taken more time, but they've come to that point. Yeah.
Okay. Yes. Because we are talking about support here. Essential support that both the caregiver and someone living with dementia needs.
Yes. So, and what the person with dementia needs is basically, depending on what their level of dementia is, what their physical care needs are. For some of them, it's having, for this lady, for example, it's having a really good relationship with the person that's come, because she hasn't got any other friends. And her family had been, I think, when she married an Australian guy, the family sort of dropped her off. They haven't kept the relationship going. And so now the care worker is the only good friend this lady has. So having that friendship is important for the person with dementia. So sometimes it's the person with dementia who's needing extra support to be able to do things. We talked today, what activities could they do together? The lady used to make jewellery. So they're going to look at sitting down and using beads to make some jewellery, and the care worker will help her where she needs it, but it'll give her a sense of purpose, and she's doing something that she used to do previously, hopefully. And the other thing was that she really loved cooking. So she can still cut up the vegetables and prepare the vegetables. So they've been doing that together already, that they go to the kitchen and she chops up the vegetables and prepares for the evening meal. So when the husband comes back from his walk, he doesn't have to do all those jobs as part of getting the evening meal together, yes.
Yes. But tell me, Isabel, how did this man come to you for support? Has somebody referred them to you? How did they know about you?
It was my niece. She was the care worker coming into the situation, and she knew I'd written the book. And so she told him about me and the book, and she told me about the situation. I said, look, I'm happy for him to ring me and talk to me. You don't know Australia, but he rang me when I was in the car heading to Melbourne, and I spent an hour talking to him in the car as I drove down the highway the first time. Yeah.
Yes. The reason why I'm asking, because I wish a lot of caregivers can reach out to people who can assist them, because there is assistance out there. When you need it, you will find it.
Yes. Yes. Yeah. And I mean, that's really important. Over the years, I saw lots of caregivers who didn't want to give up care. They felt that they were the only people who could do it. But the problem with that is that they get worn out, too tired, often get sick, and the person has to go into care, which they didn't want to do because that's why they were caring for them at home. But the end result of not accepting the help that other people can provide is that they get very tired and often quite sick. Then you've got the problem of introducing a carer into a situation where there hasn't been a carer before. And we actually talked about this today because Lee has developed this really good relationship with this lady. Lee went on holidays, and the new care worker who came in absolutely could not look after this lady. She got aggressive and she was, unable to be looked after by this person. So we talked today about let's gradually introduce somebody else as a visitor who will come, and Lee will be there as well. No good doing it with the husband there because, again, we'd have the jealousy thing come up. So that Lee would introduce this person and basically model what she's doing with the lady with dementia, so that somebody else can come in, and maybe they could do it now, instead of Lee coming 3 days a week, maybe she comes 2 days a week and the other person will come 1 day a week, so that there's a continuity of that. This person becomes a friend as well. So in an emergency, then there's two people who can provide the care.
Yes, that is needed. Yeah. Because I've realized that just like everybody, change is something that they don't really like, or they don't work well. And when there's a change of everything, environment, people who are caring for them.
Yes. And, sort of if you haven't introduced some care workers in while they're at home, when they go into care, it is so much harder. And they have to go into care so much earlier because, if you can put somebody to the home, and we talked about some of the toileting and showering issues today, that, at the moment Lee is not doing that because the husband is still able to do it. But we'll look at this second care worker being somebody who could be, and Lee's not a trained nurse or anything like that. She's just become a care worker. She hasn't done nursing.
Mm-hmm, mm-hmm.
So, for her to shower somebody would not be wise. But if we make the other person somebody who's got nursing background and can do the showering, then it's not such an issue if the husband can't do the showering anymore and somebody else can come in and say, I'm the nurse and I'm here to help you shower, and legitimise what they're doing. And that's really important to be able to do that.
So what you are saying, I wanted to talk about the transition maybe to a nursing home, that sometimes these people living with dementia sometimes go or are sent to nursing homes because the caregivers have not taken care of themselves, like they are worn out and they can't do it anymore. And the only place for their loved one to be cared for is when they are in a nursing home.
Yes. And that's even more difficult if you haven't had care workers in the home, because now not only is it they have to adjust to having people care for them and do different things for them, which they haven't had experience of before, they're also in a new environment. And there's other people in that environment as well. They're no longer with their spouse or their family. There's all these other people. Again, today I had the wonderful pleasure of going to the brand new C.O.R.E.C.A.R.E buildings where I had originally worked. Initially, when I did that, I was there for 7 years. You're looking after people in that organisation. Well, they've just built a brand new nursing home level care all the way through it. And it's divided into pods, and there's only 16 people in a pod. And the staff in that pod will always be the same staff, so they don't rotate around the whole nursing home. Mm-hmm. So the people will get a chance to know their care workers, and they will get a chance. They only have to relate with 16 people, not 40-odd people in some bigger nursing homes.
I know.
Yeah, and it's just been done really, really well. And lovely big open spaces, couple of smaller sitting areas, and a lovely balcony out the front where they can go on warm summer days and things like that. So it's just really beautifully done to minimise the number of people that the person is going to interact with and have to interact with, and making sure it's the same people all the time. Yes. I mean, really important, because you get to know your person as a staff member. You know their idiosyncrasies, you know their history, you get to understand where the behaviours are coming from. Mm-hmm. Then you can deal with all those things much more easier than if you've got, a change of, you might be on this wing this day and that wing the next day, and you don't have knowledge of who the people are.
Yes, obviously I'm thinking of the lady that you talked about, the one who broke her hip, and you didn't know, because maybe there are different people there who would not know what could be the problem. Yes. Okay. Yes. All right. So let's talk about the core principles. I really want us to dwell on this one, the core principles that you shared in your book as well. What are they? Give us examples, live examples.
Basically, I developed this because I had to give a presentation when I became the Alzheimer's counsellor. After I finished working at the hostel, I wanted to a different job. So I went to the Alzheimer's Association for a job. And they said, we want you to give us a presentation because it would involve doing some teaching and things like that. So I came up with the C.O.R.E.C.A.R.E principles. And it's an acronym. So CORE is for centering on the person, the first C.
Uh-huh.
O is for observing and relating to the person rather than the illness. And so looking for signs of pain and those sorts of things. R is for respect, maximising the autonomy, independence and participation.
Yes.
E is for environment and experiences that are enriching and meaningful. And then we come back to the C again, and C is about compensating for the things that they can't do and communicating well. The A is the fact that assessment is continual. So because it's a progressive disease, things are going to change. If they get an illness, things are going to change. So assessing the person and assessing those changes and then adapting your care requirements to those changes. You're continually doing that. The R is for recognising and respecting the families and friends because they're involved in the care and their relationship with that person is so important. And you need them. You need them to give you information that's going to help you care for that person appropriately, to understand when they go back in the past what they're talking about, to know where they've come from and what their background's been. And then E is for engaging specialised services. So you might need your home care service, or you might need the psychogeriatrician. Again, forgive me for belabouring the same story, but the lady in Melbourne had a GP but hadn't had a proper psychogeriatric assessment, so with a specialist. And so we managed to organise that. I think it was, I spoke to them in November. In January, they had an appointment and he put her on some medication which helped with her anxiety, because part of what was driving her behaviour was the anxiety when the husband wasn't there. Where's he gone? What's happening? And that's made a huge difference in her behaviour as well. So, engaging those specialised services and being willing to say, help, I can't do it myself. I need some other people. Yeah.
Yes, I want us to still go back to those C.O.R.E.C.A.R.E principles. The first one, center on the person. What does that mean?
Look, that means that everything you do has to revolve around that person, meeting their needs, understanding where their behaviour is coming from, knowing their past. If you can do those things, then your care can be what that person needs. You meet their needs, you respect their personhood, you respect the fact that they're still there. Just because they've got dementia, they haven't disappeared.
Yes.
You've got to interact with them, you've got to understand them, you've got to know their history. The story of the man who every afternoon would not go into the dining room for a meal. He'd say, I can't go, I've got things to do. And when they talked to his family, what did he have to do around meal times every night? He was a farmer. He had to go out, take his dogs with him and go and check that the sheep were safe and not near the irrigation canal.
Oh.
And so when we found that out, we said to the family, was there a time when he didn't go? And they said, yes, sometimes his children, who were grown-up men by then, would go and check the sheep for him. So from then onwards, it's okay. You can come and have your dinner now. Greg and Gary have gone to check the sheep. So it's about supplying that logical reason that fits their situation. And so knowing those things about the person really, really helps.
Yes, I think that's why the hospital or the nursing home that you said is recently opened, and they are just keeping only the same caregivers or same nurses. Yes, we are going to get this first C in there. I like that.
Yes. And then the person who finds that out only has to pass it on to 3 other people or 4 other people. because that information used to get lost so easily. I know. Yeah, we had 60 residents, 30 of them had dementia.
Mm-hmm.
Different care workers were looking after them in different shifts. And somebody would find something out, but the message wouldn't get down the track to the fourth person that was coming on.
Yes.
Yeah.
No, we have to center on the person. They're all observing and relating to the person rather than the illness. What does that mean?
Right. Too many people say, oh, don't worry about him. He's just got dementia.
Oh, God.
Yeah. No, he's a person. He's an individual and he has an illness that is changing his behaviour. We need to know the person so that we can address any of the issues that arise out of the dementia. Okay, he's going to go back to when he was much younger and he wants to go and get up at 4 a.m. in the morning and drive the train that he always drove from Sydney to Melbourne. And we have to have a reason to be able to say to him, no, it's okay. You don't have to go today. And I'm afraid I was rather cheeky because in the 1970s we had lots of train strikes. So I told the staff they could tell him he was on strike today.
You see the importance of knowing?
Yes, knowing the history, knowing the background. Yeah, and that's what I mean by that you really need to engage the person as a person who's got a history, who's got a background, and know them.
Yeah.
And engage with them in that way. Yeah. And observe them for changes, because the only way you're going to know they're in pain or know they're ill is to see those changes that happen. Yeah, the lady with the Welsh is typical. She was fine until that happened. And then we had to find out what was it that was happening that was making her more confused. What was it that made her think that she was in Wales after she'd lived in Australia for 40 years? Yeah, there was something big going on that was causing that sudden increase in the confusion. So, observing and recognising the changes and, making sure you do as best you can to address what's behind them.
Yes. And then respect, maximizing autonomy. What do we mean?
Right. If they can do something, let them do it.
Okay.
Stand back and respect that person for who they are, what they can do. Yeah, again, this afternoon when we were talking, Lee said to me, she can really good at chopping the veggies. I said, okay, let's respect that and let her chop the veggies. You can be there with her, but, somebody who's been chopping veggies since they're 14 is not going to do something damaging to themselves. Yes. It's a long-learnt behaviour. It's a long-learnt skill. So let's use it. Let's use the thing that they can do and respect their history, their background, the skills that they've had, and, let them feel useful. It's even more than let them feel useful. They are useful.
Yes.
They need that, as Tom Kitwood says, the sense of occupation. I'm worth something because I'm doing something.
Yes. If they don't use it, it's going to get lost. Whatever you don't use.
Yes, exactly.
Environment.
Be aware of the effect of the environment has upon them. The social environment. I've shared this story a couple of times recently when I've been talking, but when I was a little girl and in school, we had a relief headmaster who was not very nice, and he was short, fat, and balding back except for a rotund bit of white hair back there. And I was in the classroom and he was out of the classroom. One of the boys stole my ruler. I chased the boy around the classroom, got my ruler back. And as I got the ruler back, I hit the boy with the ruler just as the headmaster walked in the door. And I got the cane across my hand. If I went on to get dementia now, And I was in a dining room and somebody sat me next to a short, fat, rotund, balding older man,
Yes.
not be happy. I would be wanting to get out of there, and those are the sort of things that we've got to observe and see and change in the environment if we need to. It's about looking at what's happening, what might be. You don't know the story,
Mm-mm.
but the behaviour shows that I'm not happy sitting next to that man.
Mm-hmm. And
And
I
so
don't have words to tell you that I'm not happy sitting with that man.
Yes. So let's move me away, just simply because that environment is not good for me. Look at somebody who, again, we talked about this afternoon, squat toilets. If you've travelled in Europe, in Eastern Europe or in Asia, most of the toilets are squat toilets,
Mm-hmm.
where you squat down. There's no toilet bowl like the rest of us have.
Mm-hmm.
And you've got somebody who's refusing to go to the toilet and won't use the toilet. Are they looking for a squat toilet? Not what's in front of them here in Europe and the rest of the Western world. We need to try and for one lady, she used to pick up the carpet in the corner of the room and urinate in the corner of the room. And the daughter came to me, and it was just after I'd been to Russia and experienced squat toilets, and I knew straight away what she was looking for. And I said, let's put a black ice cream container in each corner of the room and put a cloth over it.
Mm-hmm.
Solve the problem. Because the environment was now the environment that she had as a child. The squat toilet, she could squat down over the top of the black ice cream container, which looked like a hole in the floor. And the daughter was happy and she was happy.
Oh.
So, just thinking
Still
of
going
those.
back. Yes, still going back to knowing them.
Yes.
But I think the dementia care sector then has got a lot of work to do.
Yes, I'll agree with you.
Let's go on to the compensate and communicate.
Yeah, so much about communication is so important. Look, I'm going to use my example this afternoon because Lee had sent me some video during the week before we had this Zoom session showing her communicating with this lady. Now, one speaks Chinese and English, and the other one is losing her English and just speaking Vietnamese. So you could see on these videos that the lady would have a smile on her face and be chattering away in Vietnamese, and Lee's looking at her saying, yes. So by her body language and her facial expression, she's connecting with this lady, even though it's not words. And then, there was a time when the lady looked a bit confused and had a frown on her face, and Lee's saying, oh, it's not good, is it? Yeah, looking the same. So, we can communicate. We tend to think of communication as our words, but our communication is far more than our words. It's our expression, it's our body language, and that's what Lee was using brilliantly with this lady to keep her happy, and she knows this person's listening to her because she's reading the body language, and she's responding. Yeah. So it's really important that we get our communication right as much as we can. And compensating is about letting them do, for example, with this lady again, with the cooking. Yeah, she can cut up the veggies, but she really doesn't have the skills to turn the stove on and do the cooking.
Mm-hmm.
So that's where we compensate. We come in and we pick up the thing that she can't do anymore, but allow her to do all the things that she can do. Yeah.
Yes, and the assessment is continual. You talked about it, something there. Assessment is continual. Do you practice that? Do people living with dementia, do they have the assessment continually, or we are lagging behind?
We're lagging behind, particularly for people living in the community they're not getting regular ongoing assessment unless the care person rings up and says, things are changing, I need somebody to come in.
Mm-hmm.
But in most aged care facilities, people are picking up on those changes as they happen.
Mm-hmm.
But are they actually addressing them as they need to be addressed? Probably not. There's changes that will happen over time because it's a progressive illness. It's going to get worse, and we need to be able to come in and address those issues and help the carers to adjust to the changes. Yeah.
All right. What do you think, in your experience, how often should the assessment be done?
Oh, look,
Or what
probably
determines?
probably at least annually,
Mm-hmm.
but it should be done when things change.
Mm-hmm. What do you mean by that?
Well, if there's increased confusion, if there's increased disorientation, if they're losing skills that they've been able to maintain even though they've got dementia,
Mm-hmm.
those sort of significant changes, if they're starting to resist personal care, starting to have difficulty eating or drinking, any sort of physiological changes, walking, falling, those sort of things all need to be addressed as they happen. So, don't just presume this is part of the disease process. It may not be. And that's where you need to have somebody look at the situation. Have they got an ongoing illness that is causing loss of ability? Are they developing an illness that needs to be addressed? Is their diabetes under control? Or all those sorts of things regularly need to be assessed, as well as their function as well.
All right. The last topic, I want us to talk about spirituality. I am a Christian, so
Yeah.
I think should I get to a point where I'm not able to articulate what I want, I would prefer my loved one or whoever will be taking care of me to be playing maybe Bible scriptures throughout, or some worship music just throughout the day.
Yeah.
For me, we talked about dementia and spirituality in your book. What do you mean? What is spirituality, and how do you relate it with dementia care?
Okay, it's really about how that person sees their own spirituality. For a Christian, and I like you, I would want the Christian worship music. I'd want people reading the Bible to me. They're a core part of who I am. And a lot of older people, particularly in the generations now, have experienced Christian church and Christian background in their childhood. So playing the old hymns and reading the common scriptures, the 23rd Psalm and things like that, really important. But then we're dealing with people from lots of different cultures these days.
Yes.
The Buddhist, the Muslim, those with no religious beliefs any longer. But they have a sense of, it may be they like to go out in nature and that's their spiritual time. Or they have some sort of way that they refresh themselves. And again, it's knowing what it is for that person. It may be putting on a nature video with just some background classical music. They address some people's spiritual need and they relax with that. So, I tried to address it in the book so that it's not just about the Christian, that it covers other people.
Yes.
And it talks about spiritual reminiscence. There's some really good work done by Dr. Elizabeth McKinley here in Australia.
Mm-hmm.
And the sort of questions that you can ask people when they're still able to articulate about their childhood, about Sunday school, about their relationship with God. And even if it's just that remembering from their childhood, it's important that you're connecting with their spirit, praying with. And a lot of the times towards the end of dementia, people can still hear, hearing's one of the last things that goes. And I remember talking to a lady from the States one day. She was a nurse and her mother had dementia, and she went to visit her near the end stages, and the mother hadn't recognised her for about 3 or 4, maybe longer, months. And when she walked into the room, her mother recognised her, spoke to her by name, and the next day died. And it's not an unusual event that they have this moment of clarity before death. And I mean, I've seen people I've known who are Christians watching round the room, and you think, what are you looking at? You can see something that's not visible to me, but there's probably an angel here that you can now see because you're on that cusp of moving from this life to that life.
To the next dimension. Yes. Oh,
Yeah.
okay.
Yeah.
Okay, like I said, I need my God. Somebody else needs something else, to connect with their spirituality. Anyway, okay. So, but any other thing that we'd like to discuss? We're left with a minute or so that we think, it will benefit us. Maybe you can talk about your book. Yes.
Oh.
How can it help us? Anyone who can get hold of it?
Anybody can get hold of it. It's available through Amazon, and I found that somebody else is advertising it on Amazon at a higher level cost than what I put on it. So make sure you don't. I'm not sure what the English equivalent is of $50 Australian, but it's around $45 Australian online, and that's what the cost should be. So if you come up with something that is charging way more, have another look on Amazon, because it just surprised me. There's these people called Amazon sellers that will buy your book and sell it at a higher price. So I've complained about it last night, but I haven't heard back.
Yeah. That's strange, because I think I bought it around, £8-9.
Yes. So, and it's $11 Australian for a ebook. So that gives you a bit of an idea. So 11 Australian for the ebook, $45.90 for the paperback copy.
Yeah. All right. No, there you heard it. Make sure that you are buying the correct one. It's not that expensive. All right. No, thank you very much. I guess I know we will get another time to have a chat again. Thank you for your time, Isabel.
Oh, thank you so much, Julia. It's a pleasure.
Dementia Care. How deep is your love?